So the question was, is the radiation oncologist a game changer? I would say, of course, yes. But in fact, the discussions that we have always with our surgeons are exactly what we just previously said. And the idea is to know if we can perform radiotherapy after immediate reconstruction, and which is the balance between the possibility to do it and the inconvenience of doing it. So two main questions to answer that. First, is radiotherapy feasible without compromising the oncologic outcome? Because at the end of the day, this is the major issue. And the second one is radiotherapy feasible without compromising the cosmetic results? Because at the end of the day, the idea of making a reconstruction is to have a nice cosmetic result. And our surgeons always says, don't worry with the cosmetic results, we can handle that, because now we have so many techniques, we can put some lipofilling, we can perform another surgery and optimize the results, and many things are possible. So just tell us if you cannot, you're sure you won't compromise the oncologic outcome. So I will focus more on that, but I will come back to the second question at the end. So, as I mentioned yesterday with the clinical cases, things have changed in radiotherapy with now techniques which are much more conformal and much more homogeneous in terms of dose. Here you can see a typical 3D conventional treatment where, as we saw in the previous presentation, 2 tangential beams to irradiate the breast, giving, of course, due to the difference of thickness that the beam has to cross here, hot spots at the entrance of the beams and cold spots in the center. So quite a heterogeneous dose. And in fact, we know that the heterogeneity of the dose is linked to the risk of fibrosis, and so can impact the cosmetic result and also can impact the risk of contracture around the prosthesis. So if we use IMRT, the difference is that by modulating the intensity of the beam, we can take into account the different in depth and length of tissue that we need to cross. And so we are able to make disappear these hot spots and cold spots, and luckily to create kind of cold spots on the normal tissue that we have behind, so either the lung or the heart. And that's back from the year 2000, 2001, but now things have even more evolved with rotational IMRT and different techniques such as tomotherapy or VMAT. So just to give you an insight, the tomotherapy machine is a kind of CT scan with an RT machine in it. So it's able to irradiate the patient by rotating around the patient, so multiplying the beam angles that you have as an option to treat your volume. And this typically allows to treat bilateral breasts really easily, integrating also the treatment of, for instance here, the internal mammary chain or the supraclav, all in one volume, all modulated, so all adapted to the volume that you want to treat. So very high conformality. Plus, you have this CT scan on board, so you are able to image the treatment you are performing, so you are able to check where the dose is actually delivered, and so you are able to have a very accurate and precise delivery of the dose. Same thing here with the VMAT, which is a volumetric modulated arc therapy, so instead of rotating all around the patient, you will make arcs, and so you will have kind of multiple beams all around part of it, so you can spare the contralateral side, and you see that even with a prosthesis, even if you have a strong shape here, you can still adapt the volume that you want to treat just by delineating what you want to treat and adapting your beam by modulating it. Again, here you can see on the machine, so that's the head of the machine where the beam comes from. And then here you see 2 arms around that rotates with the machine, and that enables creating this type of image even during the treatment or just before the treatment. So you also can precisely and accurately check where your dose is delivered and make sure that your patient is not moving, and so you're not just giving the dose somewhere else than what you planned. One very important thing to understand well the potential pitfalls of these IMRT techniques is that, as you can see here, the dose is really nicely shaped and nicely distributed. But imagine what happens if you just move a little bit. Then your perfect dose is perfectly somewhere else. Imagine what happens when your breast is swelling, because during radiation you have some inflammation and you might have some breast swelling. So if the breast is swelling, then you have a perfect distribution perfectly outside of the volume you want to treat. So it's really something very nice, fantastic on the paper, but you have to be very careful when it comes to the patient to make sure that it's still accurate. And so that's why different studies were taken out. I'm just giving you one of the most recent, which is a large Canadian trial by Pignol, randomizing patients between standard radiotherapy, 3D radiotherapy, and IMRT. And the idea with 9 years follow-up is that they have shown that there is no difference in overall survival, nor in DFS or LRFS. The only thing that they have shown, which is really important, is that you have the same long-term cosmetic and toxicity, cosmetic outcome and toxicities, but in terms of acute toxicity, you might have different toxicities with less toxicity, especially in patients, very selected patients, in which you have this different anatomy, like pectus excavatum, like prothesis, like complex volumes with lymph nodes to treat. So what we can conclude from this study and the two other randomized studies comparing IMRT and 3D for breast is that IMRT is clearly not a standard, but is really a useful tool when we need it, in specific volumes, specific shapes that are not well covered with tangential fields. And in the case of prothesis, or in the case of reconstruction, this is really a situation where IMRT can help us a lot. Another example to explain how things have evolved in radiotherapy, well, we are now combining these techniques of IMRT with other techniques to spare better the normal tissues, and namely lung and heart. You can see here a patient's free breathing during the CT scan, and so the dosimetry was done on this free breathing CT scan. So you need margins to take into account the fact that with the breath, the breast moves, and you can see here the heart of the patient. It's partly inside the fields, but if you use this breathe hold technique where you ask the patient to deeply inspirate and then hold his breath, so you guide him, you coach him, saying inspire, expire, inspire, expire, inspire, and hold the breath, and then, of course, you put your breast apart from your chest, and as you can see on this CT here, well, the heart is really moved out from the beams, and so the dose is really reduced. You might not be able to read it here, but the curve of the heart is here, and so if you look at these dose volume histograms, you see that the mean dose to the heart in free breathing was 6.8 grays, when it drops down to 2.8 grays. When you know that the EBCCG meta-analysis and the Sarah Darby data have shown that it's likely that each additional gray as a mean dose to the heart increases the risk of coronary disease and major coronary event, you know the importance of reducing that dose to the heart. And just before finishing, another improvement that is more recent, which is the body surface imaging. Because of course, again, not all is about planning, but also about the delivery of the treatment and making sure that what you plan is exactly what you deliver. And in fact, we have now these imaging modalities that are cameras inside the treatment room that are able to scan the patient, make a body surface image of the patient, and of course, if the patient moves, then the body surface image will not be the same. And so the two images will not overlap. And so the light projection of the two images will not be the same. And instead of looking blue, the patient will look green. And so you can interrupt the treatment and reposition the patient. So that's for the improvement that we have. Now, if we look at the literature and looking at radiotherapy post-mastectomy with nipple sparing, well, we have many different studies. I just selected one of the recent meta-analysis that tried to include quite a large number of studies, but finally ended up in 7 selected studies because of no access to individual data, etc., etc. But still, more than 3,600 patients. And what we see here is that there is no increase in the neck necrosis rate post-radiotherapy. There is an increase in flap necrosis, but there is a huge heterogeneity in between the different studies. So I'm not sure we really can take this for granted, and we really need for control studies that will allow us to better evaluate and assess in which situation radiotherapy is not detrimental, at least in terms of surgical complications. Last thing I wanted to mention is how we can do radiotherapy with expanders. Yes, technically, with IMRT, there's no problem. We can do it. The problem is the metallic valve that you can see here, and you can easily see the artifacts around it, and you can easily see that the Unsfield units in the valve is clearly not the same as the Unsfield units around the prosthesis. So when the beam goes through, it's attenuated in a different way than here, but most of our TPSs, treatment planning systems, are not able to take this into account. And so if you do not have a TPS that takes that into account, you might end up with a high heterogeneity in the dose, with between the series between 7 and even 20% of under or over dosage behind or in front of this valve. So a huge heterogeneity that has to be taken into account. At the moment, what we have are only dosimetric studies. We have no real evaluation of the clinical impact, and that's something really important. So in conclusion, yes, we have technical improvements that in radiation oncology makes it possible to treat complex volume and to treat and cover adequately the target volume. IMRT is not a standard for all patients, but is an option for some, especially because it gives dosimetric benefits in complex volumes. These techniques are, of course, more time-consuming at this moment, so that's also something to take into account in practice. But in the future, it might not be so much time-consuming because of automatization of many tasks in the process and the workflow, such as automatic contouring, automatic quality assurance, etc. So the other point important with IMRT is that we need for adaptive radiotherapy, so being able to replan and to recalculate the dose according to the changes in the shape of the breast, so for instance when the breast is swelling. Be careful with the metallic valves. There is some uncertainty there on the dose, so make sure you take that into account if you irradiate a breast with an expander with a metallic valve. There is a need for international guidelines on contouring, because of course I said that we can cover the target volume, but still we need to know what is the target volume. And for that we have to discuss with the surgeons, because it really depends on the technical aspects of your surgery, and that's an ongoing process in ESTRO, so in the European Society for Radiation Oncology. With modern techniques, we have reduced toxicities, of course, on the heart, on the lung, but also in terms of fibrosis on the skin. And we need, for long-term assessment, good control studies, not only to evaluate the cosmetic aspects, but also to evaluate the satisfaction of the patient. It always struggles me to see how, in some situations, we do have patients that have either a good or a bad cosmetic results, or at least what we consider as a good or bad result, and they are happy with it. So there is often no correlation between what we think is an objective evaluation of the result and the satisfaction of the patient. And in the talk we had yesterday, I think it was really well mentioned that sometimes the patients do not have the same vision as we do. So neck sparing, expanders, prosthesis, pre-op versus post-op, that's also a question that now we can re-ask with our new techniques. We still have work to do together. Thank you very much.